Thank you very much for the invitation. It's a pleasure for me being here and talking about the transition from the pediatric provider to the adult provider. And this is a very important topic for which we don't do, sadly, a very good job to handle. And we need to start in adolescence. And adolescence is a very complicated period of time because the part of the brain that controls the emotions, the motivation, and the behavior is developing faster and earlier than our brain cortex, especially our frontal cortex, which is the one that puts control and puts like the brakes on this whole emotional and high risk behavior process. And that's why it is a complicated part where we're asking the teenagers to start being independent, but some of them might not have all the skills ready to really follow through. And this is why this is a very high risk age at which there is loss to follow up and not good preparing for a appropriate transition into adult care. And it is hard to be an adolescent, much less without any chronic disease, because they have to learn to get along with friends of both sexes, achieve new and mature relationships. They need to accept their physical body and they need to keep it healthy. They need to achieve the social roles that suit with one's gender identity. They need to start slowly becoming emotionally independent from the parents and other adults. They start making a little bit more lasting decisions about intimate relationships and family life, preparing for a job or a career. They acquire the set of values and their ethical system so they can guide their behavior in the developing an ideology. And all this while trying to become socially responsible and dealing with a chronic illness. So as I said before, this is a high risk time period. And there's a lot of concerns because there's loss to follow up, there's no good access, poor medication adherence, poor health outcomes. And it is true, there is less than 50% of adolescent and young adults with chronic illnesses receive a true pediatric to adult transition planning. So it's very few patients that actually go through this. And why go through all this bother? Because we want them to achieve self-management knowledge, skills, and navigation abilities to function as literate and self-directed healthcare consumers, which is what they need to be to continue with their health and a good managing from the physician standpoint. So transfer just means to go from one to another, to go from the pediatric provider to the adult provider. And it can be either one event or a series of events through which these adolescents and young adults move their care from a pediatric to an adult environment. But a good transfer is not successful without an appropriate transition and growth. There has to be a slow process for which our patient gains individual skills through the years to achieve a very good successful transfer. So what is transition of care? Well, it's exactly this process which addresses medical, psychosocial, and vocational issues as young people move from a child to adult central centers. And it's a transition from the pediatric model of care to the adult model of care with an increase in that self-management. And even though pediatric physicians and adult physicians would treat the same diseases, we don't do it the same way, and we don't approach it the same way. When we look at the pediatric versus the adult model of care, pediatric is multidisciplinary, especially within the neuro-GI field. Adults often single MD. Pediatric is family-centered. We're trained from the beginning to involve the whole family in the decision and in the process, whereas adult care tends to be a lot more just patient-focused. Pediatric model is protective. We want to protect. The adult model is more collaborate. In pediatrics, who carries the responsibility is the parental responsibility, The parents make the appointments, the parents fill the prescriptions, the parents talk to the pediatrician, as opposed to an adult world where we expect them to have that autonomy. In pediatrics, patients are dependent on the parents, and adult providers independent. They usually attend alone to the doctor or maybe with a partner. The patient in pediatrics tends to have a passive role in decision making. Some families are better at others at engaging the child, and all the physicians are better than others at engaging the child and giving a role in decisions. But in general, pediatric patients have a passive role in this decision making, and adult providers have an active role in their decision. Of course, in pediatrics, as we talked earlier, because of the high-risk behavior and the behavior center developing at different times in our frontal cortex, there is an immature attitude to risk. A teenager would acknowledge that there's risk, but they don't comprehend that the risk would ever happen to them, as opposed to adults who have a better understanding of risk. In pediatric, all their appointments get managed, and in adults, they're responsible for assessing the symptoms, organizing appointments, and getting where they need to be. So what's the key to a successful transition? Well, to do it slowly and independently, educate our patient in the disease, in what medications they take and what do they do, what are tests, when are they required, and how are they performed. Also working on their independent health behaviors and self-advocacy, patients to start talking and having more and more key input in the decision about medication, about testing, about treatments, and a more mature understanding of the effect of drugs and smoking, the consequences of not following the physician's advice, and a healthy growth of the fertility and the sexuality. So the goals are that we have a continuum of care, that the patient doesn't go from having a physician that takes care of their disease and they drop in gap in care. We also want them to have acquisition of self-management skills and plan what do they do when their disease flares up if this happens. These type of questions are from a questionnaire to show about medication self-management. So we can ask the patient, do you fill the prescription if you need to? Do you know what to do if you're having a bad reaction to your medications? Do you take medications correctly and on your own? And do you reorder the medications because you run out? And all these things happen by the parents, and all of a sudden we can't give this to our patient to do it by their own, by themselves. They've never done it. And it's not only about medication, it's about adherence. And it's about having the knowledge about your illness. It's about taking the medicine, prescribing them, but it's about making the appointments. It's about maintaining a healthy diet and how to properly seek medical attention, when to go to the emergency department, when to go on an emergent visit to the physician, when to go and make your regular scheduled appointments. Have good physical activity, mitigate bad behaviors, and have a continuum under immunizations. And all of this is going to lead to better health and better adherence if we do it. And it's not going to happen over time. We need to introduce a concept before 14 years of age. That way we have ample time to slowly be involving the patient, achieving every time more responsibility and more understanding of the disease. And the transition can happen anywhere from 18 to 21 years of age. But if we're not already working on this since before, then we're not going to achieve a good transition, and a lot of patients are going to fall through the cracks, which is what we don't want. Also, we can help with transition to college, dormitory accommodations like restroom access or meal plan, as well as academic recommendations. So it's important that patients learn to advocate for themselves and stay connected with their physician. And what are the barriers? Well, the family and patient get attached to the team. They sometimes don't comply with looking for another provider until it's too late. And sometimes you can have parents that are a little bit resistant to losing that role in the patient care. And from our perspective, we also get attached to our patients. So we deny and don't like to let go. So it is our fault as well. And sometimes in our area might not be qualified providers for different pediatric challenges that are not common in the adult population. We had this problem in our colorectal clinic where we have patients with cecostomy tubes. It was very hard to find an adult provider that actually was willing and interested in taking care of this population. And sometimes there's institutional limitations, there might be insurance limitations or geographical limitations. So in summary, education is key. It's very important to increase self-management. We can use transition tools and checklists that can help standardize this process. We need to discuss this with the patient and the parents early in adolescence and open up this communication between the pediatric and the adult provider so that it is a smooth transition. And adult providers must do their part as well to continue the transition process. And with this, I want to thank you all for taking the time of listening and can accommodate any questions. Thank you.